Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is John D'Amore. He has had over 15 years of experience in informatics and strategic thinking in healthcare organizations. Most recently, he's founded Diameter Health, which is a health IT company working on improving clinical, operational, and financial outcomes through intelligent normalization of data. He's previously been a VP at an EHR company overseeing enterprise performance management solutions and has worked on the provider side of the street as well at Memorial Hermann in Texas. Welcome, John, and thank you for joining us.
Thank you so much, David, for having me here.
So, John, in your work on health data over the years in health IT, you have seen many ideas and many rules come and go, and the latest rule that's rolled into town is under the Cures Act, the final rule, which has been noticed, promulgated, delayed, not delayed. Tell us a little bit about that. Where are we in terms of implementation here? What is rolling forward and what has been delayed at this stage of the game?
Absolutely. Giving just a little bit of perspective on the Cures Act, it comes out from a basis of where things have progressed in the last decade for health IT and health data generally, which is during the Meaningful Use program, which was actually part of the Stimulus Act from the Great Recession back in 2008, 9, 10 timeframe. There was a lot of push for providers to be able to codify, store, and make available clinical medical information that they record in electronic health records and to adopt electronic health records generally. That program has been very successful for providers. In rolling that forward into the Cures Act and the regulations from CMS and ONC, Centers for Medicare and Medicaid Services, and the Office of the National Coordinator for Health IT, that came out in March of this year, I think of it analogously as putting a lot of those constraints and requirements on health plans, payers, insurers, that they were put on providers a decade ago to be able to codify and share information using digital standards and be able to make that available first to the member, which I think is a great step forward. It's the power of thinking that you and I and other people will be able to walk in, or really not walk anywhere, be able to take our cell phone, log into our insurer's credentials, and be able to download the data that insurer has is a pretty powerful step forward. One of the things that has always been hard when you think about gathering your medical information is that it's often spread across a lot of different sources, and health insurers have a unified view. So I think it's a really powerful step, and starting with the patients and the members is really where ONC and CMS are getting started with these new rules that came out in March.
Sure. Just to jump in here for a sec, the rules and sort of the context of these rules has been really focused on the technology vendor community, on the provider community. And if I were a payer, sort of watching this unfold over the last couple of years or longer, I would think this is coming at me out of left field. Why am I now sitting here in the hot seat subject to these requirements? And what do I bring to the table? I have a lot of claims data, but I don't really have clinical data. What's going on here?
Well, that's the nugget, which is having the claims information is pretty powerful. It's not very timely because there's obviously a delay between when you have a visit and when a bill gets generated and when really that information goes to the insurer through clearinghouses. But it's longitudinal in nature. So your health plan is going to know all the doctors that they've paid for your care, all the facilities, whether it be an ER or an urgent care or a PCP visit, a specialist, or a hospital stay. They're going to have a longitudinal and a holistic view that was lacking when providers were making this information available. A hospital would know about you during the time you were in the ER or the time that you were during a hospitalization. They wouldn't necessarily know what happened next for it. And that claims information gives you at least a venue of the services that were provided and paid for by the insurer. But interestingly, health plans over the past decade have massively upticked their ability to ingest clinical data for a whole variety of purposes, which is they're using that for care management, for things like prior authorization, for things like quality measurement, population health, even things that are predictive in nature for patients that are going to progress in disease, and also risk adjustment, because the federal government has really made a big opportunity, especially for a lot of health plans in the Medicare Advantage markets, to service Medicare members. In the 2000s, Medicare Advantage was a small portion. It was still meaningful, but it wasn't necessarily a majority. We're moving towards a majority of Medicare patients being in the Medicare Advantage program in the near future. So I think that has put additional scrutiny and pressure on them to provide more services now that they've really opened up new markets. And they do have a lot more data. They have that longitudinal claims or billing data, but they've got a lot of clinical information on their members as well.
Right. There's an awful lot of care management work that's done both on the provider side and the payer side. And in many ways, it's as if there's this convergence of payer and provider functions. And some folks speak of, payviders or, provider organizations that are holding risk. And we have rules coming out in the near future about expanding the options in value-based payment arrangements. Mm-hmm. And that will sort of create a whole new cottage industry in developing those models and those relationships. And there will be more kinds of data, more streams of data to manage in that context.
And to pick up on that thread, that's exactly where this is headed. I talked about the requirements for the members to first access the data beginning next year. The current timeline is July 2021. But the ability to be able to make that data available to those new risk-sharing arrangements is absolutely where it's going. Every provider that's beginning to take on risk and be responsible for not just the quality of care, but the efficiency of care and the utilization of services, they need to have access to the payers, the insurers' data. And the real data standards that are pushed as part of these rules are going to be the format by which people interchange. It's going to be the coin of the realm or the currency for health information on a go-forward basis, which is really part and parcel why this is such a historic and important rule for health payers, is that this is going to be setting them up for what the next decade of health information exchange between payers and other organizations, and even payer to payer, will look like.
Are they ready for this?
The short answer is no, because this is very new to them. I think that we work with a variety of health plans nationally, some of the biggest that certainly everyone would know about, and also some that are very regional, very state level, that don't have a national presence necessarily. And we see a variety of preparedness. We see a range of kind of understanding for how things are changing in this ecosystem. I think that certainly everyone has compliance on their mind. Everyone is thinking about, how do I get something so that when CMS comes along and wants to check out, that I am able to make this information available in the new standard called FHIR, or FHIR, Fast Healthcare Interoperability Resources, through an API, that they are able to do something. So they're all thinking about that. But I think that the ones that are going to be positioning themselves to more success are not thinking about this solely as a compliance requirement, but they're thinking about this in an enterprise framework, where this mode of exchanging information, these standards that they're now being forced to use, will actually support a lot of more interchange and interoperability in the future. And also, it's going to have an impact on even things like member satisfaction. When members access this data for the first time by a health plan, that generally they have not had access to a lot of this information previously, if it's duplicative, confusing, hard to use, that's not going to be a big satisfier in how to engage that member in their own health, which is obviously a very consumer outreach, and engagement is a key strategy for virtually every health plan that I speak with. So I think the ones that are going to be more ready are the ones that are thinking about this as an enterprise and not thinking about this solely as a compliance task. But for all of them, even if they're just thinking about it as a compliance task, they do have a lot of work to make this information available in 2021.
Yeah, but as you say, if it's being viewed as a compliance obligation, folks will do the bare minimum. If they see a business driver for doing this and a patient or member driver and demand for data, and there's always a growing chorus of voices on that front, then there's more likelihood that this will be taken seriously or more seriously. So what you're saying leads to two interrelated questions. One is, what exactly, if I am a member of a health plan, what will I be able to see come July 2021? What will be accessible to me that is not accessible to me now?
So the one thing that will be very common to all health plans is going to be the 5 years of information about services rendered, copay and deductible information, essentially a subset of all that billing data. You won't necessarily be able to say every partial adjudication that's been done in work streams for billing, but you'll be able to get a picture of, hey, I had this hospitalization. This is how much they paid. This is how much I paid, and on this date for it. They'll be able to see that claims-based information. But there's also a requirement, and very explicit, that any clinical data maintained by the health plan also has to be made accessible. And so that means that the lab results that the health plan has been receiving on their members, things like medications, allergies, problems and diagnoses, things like procedures, social history, vital signs, those things have become critically important for quality programs for payers, like the largest one, HEDIS, which is managed by the National Committee for Quality Assurance, or NCQA. Those things have to also be available, and it has to still go back that 5-year time frame. And the actual timeliness of the data is meant to be next business day. That's actually in the regulatory requirements. I think that will be pretty difficult for most health plans to be that timely. But just having access to that full picture of, everyone knows what they put in for their health insurance payments on a monthly basis through their employer or through an exchange, and looking at what their insurer is actually paying for and how much they're paying is going to be a new level of transparency for the individual consumer.
If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is John D'Amore of Diameter Health. John, what are the things that payers need to do today in order to be ready for July of 21?
I think that the thing that we've found that's very common is to be aware of where the hard problems are going to be. Essentially, the common lesson learned is to understand what's going to be the longest pole in the tent, what's going to be the hardest thing to making this data fluidly available first to members, but then knowing that CMS has set out a multi-year plan that you'll need to make this available to other payers and eventually even to providers in the future as well. But the biggest kind of hurdle in that is getting your data ready, that migration of legacy data. A lot of people look at the technical standards and say, all right, I need to put up an API, an application programming interface, which is how most modern web applications work. It's kind of how your phone requests data, whether it be your GPS or whether it be a lot of other information, interacting with applications and texting and all those good things. The ability to bring that data into the current format and make it available via that API is actually a lot harder than just buying something that will stand up those APIs. And that's really going to be important because you want to be thinking about just the volume of information, which is a high quantity, but getting the highest quality information possible available. And you'd say, well, what's the payback? What's the ROI for high quality data to a member? And certainly I think that there's an element of member satisfaction for that. But really the payback's going to come in spades when you go to that enterprise use of this data. When you think about how to use this data over the long term for many different use cases, things like prior authorization and care management and population health, and that this becomes the centralized, again, currency for how to exchange and talk about this information using that new FHIR standard, that's going to be the real ROI, and really getting your information in a high quality format, really normalized and usable, actionable, and universally accessible. That's going to be the hard thing for most of these health plans as they go into next year.
I want to take a bit of a sidetrack. One of the things you mentioned was prior authorizations, which nobody likes. I'm sorry for all your prior auth fans out there, but I think you're few and far between. Are we approaching a day where we can extract some understanding from data such that we can automate prior authorizations? I mean, that's happening in pockets here and there. Are we at a point where we could do that more universally?
So this is where there's an intersection between what's happening from a regulatory framework and what just happened to all of us in the world post-pandemic. which is a lot of the manual processes that have been in place for prior authorization and for a lot of other things. You think about a form being mailed to your doctor. Often now it comes in a PDF so they can get it online. They have to fill it out and they have to either fax it back or they can upload it to some sort of thing. But someone has to look at it at the payer and review it and then figure out whether you're authorized for that service. A lot of that got turned off when we all get prepared for dealing with an influx of patients dealing with COVID. And what we're seeing is that people are beginning to look at this and say, now that we've turned these things off, they began to look at other flows of information that they could use to support the same task and to do it in a better way. And as they think about this, as we emerge from the pandemic, I don't think that people will be saying, let's reset and go back to all of those manual processes. There certainly will be a manual portion of prior authorization and several other tasks from payers for the foreseeable future for some patients. But if you could take 50% of all of those manual tasks and automate them, which is what several of the leading payers have begun to do. In using some of the new things, there's a work group between EHRs, providers, and payers called Da Vinci. It's an HL7 work group. HL7 is the standards development organization. They've been working on prior authorization and again, how to use that FHIR standard to facilitate a much more automated, a much more seamless transaction. And from my experience, there is a large portion of things that can be automated, and that's going to be a cost savings for payers and providers. It's also going to be a real lift of frustration. You talk about it, why nobody likes prior authorization, because nobody likes having a doctor saying that you need something and then having to wait for another review or kind of the payer's opinion on that. There's a lot of things that can flow a lot faster when we really begin to use that digital ecosystem that we've created over the past decade, and that these new CMS and ONC rules are really pointing how that data will be formatted and exchanged on a go-forward basis.
So you speak of an ecosystem, and it is sort of a nascent ecosystem, I would say. Is it working? Does it do things? Does it make the world a better place? Does it make things easier? Or are we still in early days in terms of interoperability on the ground?
So I think that there's two lenses to look through that. And there's one that's very positive. We actually have authored a post about how many digital charts, and by a digital chart, we talk about a chart that is both human readable but machine readable, which means you can get codified and structured information around what diagnoses you have and what medications you're on. When you look at the exchange of that in the real world, we have grown exponentially from 2011, 2000 timeframe to today, where those digital charts are flowing by the billions annually. And really every care encounter virtually, that's flowing out to health information exchanges, to health plans and payers, to risk-bearing organizations that are involved in value-based care. Interoperability is already happening at one level in servicing and beginning to build that ecosystem of digital data to support a lot of these workflows and activities. So I think that there's one lens of optimism to think about for the future and where things are, which is we've made a tremendous amount of progress. There was a New York Times article talking about how the fax machine is still killing healthcare 20, 30 years after every other industry has moved off. And I think we are at a point where we're beginning to see a transition. And again, that convergence with the pandemic has forced people to find ways to use digital data more innovative and more creatively. But through the other lens, I think that one way that people want to look at the world is to say, I have everything from all my financial data on my phone or on an aggregator app that allows me to look at that and pull together my budget, my expenses, and my retirement accounts. I can order groceries online, and they look at healthcare and the basic things that they can't do that are so vital to the delivery of healthcare, and they look at that consumer ecosystem, and it is still very nascent. We don't have the apps. I think Apple, through HealthKit, has begun to really take this quite seriously. There's a lot of things from Google and other companies that are starting to get in there, and there'll be just like we have other companies that service applications that we couldn't have imagined 10 or 15 years ago, like Uber and Lyft, that use APIs and digital data to deliver services in a way that we didn't think. We will see that happen in healthcare, but that will take a longer period of time because we're not on the verge of just making the data available and then that happens. There's going to be a forming stage after we pass this critical step The critical step is that the federal government, that the agencies, that the health plans begin to really exchange data in a modern format. But then there's going to be a lot of work that has to get done to make that data universally usable and accessible throughout the ecosystem. So I think that from the consumer basis, I still think we're many years out. But from the lens of interoperability happening to support business processes in the background of healthcare, things are moving really quick and sometimes hard for the average patient, certainly, to see that.
Well, looking through those two lenses may be giving us a bit of a headache, but we'll have to live with that. I wonder if you could speak more about sort of what has happened over this past year and the changes, the tremendous changes that may be happening in the background as a result of moving so much care to remote or asynchronous or to telehealth services while certain critical care is provided in person.
So the advent of telehealth, which is obviously, it's not really just been invented this year, but it really just changed the world in this past year as part of the pandemic and the response to that, has really begun to shake up a lot of expectations from health plans and from providers about how they do business. There were so many clinicians who said, I'm never going to do telehealth. I'm never going to do virtual visits. And those same people have now created an ecosystem where their EHR is connected to online meeting platforms and that they can collect the information, and that the health plans and Medicare have said that they'll pay for this. That this is a meaningful way to revolutionize things. So I think that has been a real change in the back end and in this infrastructure. But the other thing that we're seeing is the natural thing that happens after you have a paper to digital transition. It takes longer than a lot of people expect to be able to see the real moves shift once you've actually gone from a paper chart, which really, for hospitals that happened in the 2000s, and for a lot of ambulatory practices that happened in the 2010s or the teens. It takes some time for people to understand how to begin to use that new data that they have, how to innovate workflows, how to be able to really start cracking down barriers, things like prior authorization, things like being able to look at risk adjustment, things like quality measurement, and really think creatively for that. But we're beginning to see that happening in just so many pockets throughout the nation. I spoke at a NCQA event, and I used the term that the future is here. It's just not evenly distributed, which is obviously something quoting from somebody else. But when you look at what's happening in Michigan for the sharing of information fluidly between providers and health plans, all in the same room at the same table talking about that exchange. When you look at different things that are popping up on a national basis for how to exchange this data, how things are starting to form for national clinical clearinghouses, I think it's incredibly powerful to see that change. Things happen slowly in healthcare, but then when you look back over the course of sometimes 5 to 10 years, they are night and day. It's very hard to go find a doctor who has a prescription pad anymore. And we all lived through that for many, many, many years. But e-prescribing started slow and then was prevalent. We're beginning to see that with digital charts, beginning to see the fax machines actually seeing declining volume. We're beginning to see things that are actually changing that ecosystem in very meaningful ways. And they complement these rules, and they complement the pandemic, frankly, in terms of making this a lot more automated, a lot more standards-based exchange of information, and setting us up for a good spot on a go-forward basis. So while I agree that looking through two lenses, one that's a little bit cloudier and going to take longer, and one that's very exciting, it can definitely give you a headache for it. I'm actually very optimistic on where things are set up for the next several years.
Great. So I'll take that as a segue to my final question, which is, if you were to wake up tomorrow and find yourself 5 years in the future, what is one thing in healthcare that you would hope or maybe expect to find has changed drastically?
So I believe that what we will have in 5 years from now is a much more robust set of endpoints, which are technically URLs or ways to interact with this information. And we will have begun to see these proof points of clearinghouses and also the big players in tech begin to wade over to aggregating this information in ways that they hadn't done previously. I think that we're still going to be wrestling with that challenge of making it really meaningful and usable. There are many companies who thought that we're going to unleash machine learning on medicine, and we're going to go ahead and have a virtual doctor or a robo-doc in a few years. That's not going to happen in the next 5 years for it. But what we'll begin to see is that we're going to have these micro tasks that become much more powerful and much more evolved, and really begin to become the norm in healthcare rather than the exception. And I think about things like that have demonstrated huge advancements in the past decade. Being able to do machine learning, so you have automated interpretation of things like retinopathy screenings or MRIs or CT examination. I think that those things will begin to show themselves in this ecosystem where we'll find, because we'll have access to all that data, we'll have that ecosystem of API endpoints, we'll begin to have micro tasks and services that really start to deliver some pretty meaningful value for clinicians. But we won't see a future where your phone will answer all of your medical questions and become your doctor in the next 5 or 10 years. I think that one will take longer, but it's going to be setting the foundation for a lot of the future by having availability of that data. A lot of the rules that came out this past year, went under the term of how to prevent information blocking. And I think about this as a future where information, when it's should be flowing to an individual or to a different organization in the healthcare setting, often hasn't flowed previously. And I think we're going to see that being broken down, not necessarily completely behind us in 5 years, but I think we'll see meaningful progress.
Well, that's a very positive spin. Thank you for that. And John, thank you for joining us.
David, really appreciate the time. Thank you so much for having me on, and really, fun to talk about these issues in healthcare, which are just incredibly timely and important for health plans, but really all healthcare organizations. And you definitely know your stuff.
Thank you. You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.